Hi everyone, my name is Jana Zgheib. I'll just give a quick introduction about myself before I start. I hold a Bachelor's of Science degree from the American University of Beirut, and I recently obtained a Master's of Science degree in Audiology uh, from the University of Southampton. I'll be talking about audiometry, just the basics in audiometry in both adults and pediatrics. So before audiometry, it's very important to do a couple of tests, such as make sure to get a clear case history from the patient, do otoscopy, do tympanometry, and if you have time, do acoustic reflexes, and that would be optimal. These tests help you with knowing your patients and adapting parts of audiometry based on them, such as if you know your patient has tinnitus, you'll know that it would be better to use a warble tone instead of pure tone. I'm also going to quickly discuss RINNE and Weber tests. Sometimes they're done before doing audiometry, just to know a bit more about the patient. So how is the RINNE test done? First, you strike a 512 Hertz tuning fork and then place it on the mastoid bone behind the ear. After, you wait for a couple of seconds, like 2 to 3 seconds, and then you move it to next to the ear canal or in front of it, as you can see in the picture, of the same ear. Once you're done, also for a couple of seconds, and once you're done, you ask the patient, where was it louder? Was it louder on the mastoid or next to the ear canal? How do you interpret the results? So if the sound was heard stronger in front of the ear canal than on the mastoid, then this shows either a normal hearing or sensorineural hearing loss, and this is known as a positive test. If the sound was heard stronger when the tuning fork was on the mastoid bone instead of in front of the ear canal, then the patient probably has a conductive hearing loss, and this is known as a negative result. For the Weber test, you also use a 512 Hertz tuning fork. You also strike it, and then you place it on the middle of the patient's head, as you can see in the picture. Then you ask the patient if the sound they heard was equal on both sides, or if it was stronger on one side compared to the other. And the results, if the sound was perceived centrally or equal on both sides, then this is probably normal hearing. And if the patient has a conductive hearing loss, then sound will lateralize to the affected ear. And if the patient has a sensorineural hearing loss, sound will lateralize to the better or the normal ear. I'll give a couple of examples on that. So let's say the RINNE test was positive bilaterally. That means it was normal, no conductive hearing loss, either normal or sensorineural. But on the Weber test, it lateralized to the right. Since it lateralized to the right, first of all, we know it's not conductive. So most likely it's a sensorineural hearing loss in the left, because for sensorineural hearing loss, in the Weber test, it lateralizes to the normal ear. In this case, the normal ear was the right ear, so most probably it's a sensorineural hearing loss in the left ear. Another example, RINNE negative on the right, so that means there's a conductive hearing loss in that ear, and Weber, it lateralized to the right. That tells us that it's most likely a conductive hearing loss in the right ear, because in Weber it lateralized to the affected ear since it's a conductive hearing loss case. Third example, the RINNE was positive bilaterally, so most probably normal or sensorineural hearing loss. Weber, no lateralization. So in this case, it's either normal hearing in both ears or bilateral equal sensorineural hearing loss. Okay, adult pure tone audiometry. So we have two kinds. First, we have the screening audiometry. It's from 500 to 4,000 Hertz, and it's done at the upper limits of normal hearing, which is 25 dB. Some clinics use 20 dB as the upper limit of normal hearing. So what you do is just to sweep through these frequencies, 500, 1,000, 2,000, and 4,000. At 25 dB, and if the patient hears it, that's normal, that's good, that's a pass, and if they don't, then that's a refer. The second one is the threshold search audiometry. That is where you want to search for the exact threshold of the patient, and you test the softest sound a patient can hear at each frequency 50% of the time. We start with the better hearing ear, or what the patient perceives to be the better hearing ear, and you begin at 1000 hertz since it's the frequency that has the best retest reliability and it's easily heard by most. You start at the clearly audible level, which is usually a 30 dB or 40 dB HL. And then you employ a down 10 pattern if the patient hears it, and you keep on going down by 10 until the patient doesn't hear it anymore. Once they don't, you go up by 5 dB until they do respond, and when they respond, this is the first ascending response. We want the patient to respond consistently 2/3 of the time in the ascending order, and then we record that as the AC threshold. Once we're done with 1000 hertz, we move on to 2000, 3000, 4000, 6000, 8000. We go back to 1000, retest, and then move on to the low frequencies, 500 and then 250. In some clinics, they choose not to test at 3000 and 6000. So it really depends where you are in the world and what your clinic does. Bone conduction is measured at 500, 1000, 2000, and 4000 hertz. It's not ear specific unless we do masking, so it's always the better hearing ear that's responding when we don't do masking. In bone conduction, it's very important to take care not to misinterpret a hearing threshold and consider it vibrotactile threshold, because not to misinterpret a vibrotactile perception as a hearing threshold, because the bone conductor vibrates especially at lower frequencies and sometimes not at very high intensity. So for example, at 250 patients can perceive a vibrotactile sensation at 25 hertz, which is why a lot of clinics don't test at 250, because it's very low. So sometimes it's not necessary and it's useless. It doesn't really give you anything if the patient can just feel it rather than hear it. At 500 hertz, it's usually at 55 dB, and 1000, it's at 70 dB. So really be careful not to misinterpret a vibrotactile perception as a hearing threshold. Now moving on to masking. Masking is needed when we suspect that the non-test ear can detect the signal coming to the test ear, because there's a big difference between them. What is this big difference? It's when this difference is bigger than something called an interoral attenuation. It depends on what you're using. So it's either the interoral attenuation of the headphones if you're using headphones, or of inserts if you're using inserts. These are the cases where masking is needed. First, if the difference between the test ear and the non-test ear, either air conduction of both or air conduction of test ear versus bone conduction of non-test ear, is greater than or equal to 40 if you're using headphones, or greater than or equal to 55 dB if you're using inserts. In this case, AC masking is needed. For bone conduction masking, if the air conduction threshold and bone conduction threshold from the same ear is greater than or equal to 10 dB, then bone conduction masking is needed. Some clinics use greater than or equal to 15 dB. So again, it really depends where you are and what and how your clinic works. So what masking does is it temporarily elevates the hearing threshold of the non-test ear by presenting this masking noise, usually a narrowband noise, so that if we're giving a signal to the test ear, it's harder for the non-test ear to detect it. I'll give you an example here. So we have an audiogram in front of us. We can see that at 250 and 500 hertz, no masking was needed because the difference between the threshold was really small, less than 40 dB. Let's imagine we're using super oils in this case. But you can see that at 1000 hertz, they needed to use masking. So we know in this case that the left ear was the threshold in the left ear at 1000 hertz was 40 dB worse than the right ear. And that is the case for all the other frequencies actually. So the difference between two ears was greater than or equal to 40 dB, so they had to mask. How do we mask? We start for AC masking, we start the masking at a level that is 10 dB above the air conduction of the non-test ear. So again, going back to the 1000 hertz in this example, we can see that the air conduction here is 5 dB. So the initial masking would be 10 above that, so it's 15 dB. For BC masking, it's air conduction of non-test ear plus something called an occlusion effect, and then plus 10 dB. The occlusion effect depends on the frequency being tested and on what was used, headphones or inserts. After the initial masking, what do we do? So we presented masking at 10 dB above the air conduction of the non-test ear, and we're presenting the pure tone at the unmasked threshold of the test ear. We start increasing the masking by 5 dB steps if the patient is still responding to the pure tone. Once they stop responding, we start increasing the pure tone by 5 dB until they respond. When do we stop masking is when we increase the masking by 5 dB steps consecutively in three increases, and they gave us the same tonal response from the test ear. So we didn't have to increase the pure tone, and we just increased the masking in 5 dB steps 3 consecutive times. This is when we reach the true threshold of the test ear, and this is called a plateau. I'll give you an example here. Okay, so let's imagine we use super-orals in this case. We have the masking noise here and the tone in the test ear here. The threshold in the non-test ear was 10 dB. So the starting point for masking is 10 above that, which is 20. So, and the unmasked pure tone in the test ear was 60 dB. So in this case, the masking was presented at 20 dB and the patient responded at the same frequency. So we increased the masking by 5 dB. And the patient didn't respond here, so we increased the pure tone by 5 dB. They responded. We increased the masking, didn't respond, increased the pure tone by 5, they responded. We did that until we reached 35 dB of masking. At 35 dB, the patient responded at 75 dB pure tone in the non-test ear, and the test ear. We increased the masking by 5 dB, they still responded at the same pure tone, another 5 dB, and they responded at the same pure tone. This is 3 consecutive 5 dB increases of masking. So we conclude that this is the true threshold of the patient, 75 dB. In this case, they kept on increasing the masking just to show you that if you increase it too much, we reach something called overmasking, which is when the masking in the non-test ear is too loud, so it's crossing over to the test ear. Okay, and now we have something called an extended high frequency audiometry. This is done from 9,000 to 20,000 hertz, and it's usually used in the early diagnosis of hearing loss in a couple of specific conditions, such as if the patient is receiving a cisplatin-based treatment, it causes ototoxicity. So we do extended high frequency so we can detect the hearing loss earlier and let the doctor know so that maybe they can change the treatment or do something else. It really depends. And another condition is for noise exposure. It also gives an early warning for noise exposure. And it's also used when a patient is having difficulty understanding speech in noisy environments. It helps the patient understand this unexplained difficulty because usually the regular audiometry shows a normal hearing, but if you do extended high frequency audiometry, it can show you that there is an abnormality there. So it really helps in that, and there is a substantial evidence to show that when extended high frequency thresholds are lost, so is optimal hearing. And it was also shown that in difficult environments such as highly reverberant or noisy rooms, so for example in a church or a very noisy restaurant, higher frequencies like frequencies above 5 to 6 kilohertz are used to distinguish speech sounds. So they're really important. So it's good to know if the patient is losing these important high frequencies beforehand. Another form of audiometry, or just an extension to audiometry, just like the extended high frequency, is the uncomfortable loudness. The stimulus used is pure tones and sometimes warble tones or frequency modulated tones. And in this test, we're using really high intensity sounds, so the audiologist has to consider the potential risks and benefits from this test for each individual patient. So you have to weigh them and see if it's going to do them more harm than good, or vice versa. Usually levels above 110 dB should not be used. That is what is recommended. And levels above 100 dB, they should be used with caution. It's done one ear at a time, and sometimes only testing two frequencies can be enough, one low and one high, such as 500 and 2000, or 500 and 4000. You present the tone for 1 to 2 seconds and increase it by 5 dB if the patient didn't report any uncomfortable feeling, and you give a 2-second pause between stimuli. And it's very important to monitor the patient's face for any sign of flinching, distress, or just obvious annoyance and pain from it. And if that is shown, you stop testing immediately. And the instruction is really important in this test. So you have to tell the patient that they need to press the button as soon as the sound becomes uncomfortably loud. And this test is not to find the loudest sound they can tolerate. So they don't have to tolerate anything. As soon as it becomes uncomfortable, they have to press it. And this audiogram shows you how it's written. Some people use a U, some people use an L. It also depends where you are in the world and what your clinic uses. I have a couple of examples. So in this case, we can see this is the same patient, right and left ear. The lines above are 60 days after cisplatin-based treatment. We can see some hearing loss in the high frequencies here. And the line here is 90 days after cisplatin-based treatment. We can see that the thresholds got worse. And if we have the extended high frequency audiometry for this case, they will show you the same thing. They start getting worse as long as the patient stays on this treatment longer. This is another example that shows you presbycusis case. On the right, we have the patient age 66, just basically normal hearing, just a slightly sloping high frequency hearing loss here at 8,000. And this is the same patient at 82 years old, and we can see that hearing loss got worse and it's sloping more severely now and affecting other frequencies, 2,000, 4,000, 8,000. One more example, this shows you otosclerosis in both ears of the patient. We can see, because we can see the Carhartt notch at 2000 hertz, which is a signature thing for otosclerosis cases. Conductive hearing loss and Carhartt notch at 2000 hertz. Moving on to the pediatric population, we have, first we have behavioral audiologic assessment. This is done for infants less than 5 to 7 months developmental age. Frequencies used are 500, 1000, 2000, and 4000. The stimulus is a warble tone or a narrowband noise. You start at a clearly audible and very comfortable level, usually 60 to 70 dB, and then you go down by 20 until you don't have a response, and then up by 10 until you reach 2 repeatable ascending responses. It's very important to observe the child for a period of time to obtain a baseline of his or her behavior, because we want to know what changes does when you present the stimuli, what changes in their face it gives. So things to look at are uh, eye blinks, eye widening, or startled responses. These reflexive behaviors show you that the child heard this response. There are a couple of limitations for this test because the infant will respond at a wide range of intensities. They're not very reliable, as we know, and there's a quick habituation of responses, and also there's an observer bias. Findings in this test are referred to as a minimal response levels, and these responses vary as a function of stimulus, as a function of developmental age of the patient, and the infant's state. It's very important for the infant to be relaxed, but also alert. If they're too active or too fussy or too tired, the minimal response levels will be too high, or they may not be observable. And age and signal intensity have an inverse relationship. So usually when the child gets a bit older, they can detect softer intensities. Now off to visual reinforcement audiometry. It's used for children over 8 to 9 months old, but younger than 3 years old. So the first tester right here presents the sound. The child is here, turns to search for the sound, and then the reinforcer is used and the toy is activated. And usually it's an animated toy hidden behind a dark glass cabinet, and it's only revealed when it's activated. There are loudspeakers at 90-degree azimuth. Sometimes there's only one, sometimes there are two, and they're almost at a level with the child's head and 1 to 2 meters away from them. This test can be tested using sound field or under earphones or even through a bone conductor. The stimulus type used is a frequency modulated tone, warble tone, or narrowband noise in case we're using speakers. So we start at a 2 kilohertz stimulus and at an adequate suprathreshold level, same thing as the behavioral observational audiometry. So it's like 60 to 70 dBHL. And but you can choose a different frequency if you think it would be more appropriate for the child. So if you think that the child has low frequency hearing loss, you can start at a higher frequency, or if you think they have a high frequency hearing loss, you can start at 500 hertz. When you present the sound, if the child turns their head, then you present the reinforcement in combination with the sound. And same thing as BOA, you drop the level rapidly in 20 dB steps. No response, you go up by 10 dB. And the presentation level throughout the whole test is determined by the tester based on a couple of factors, such as the age of the child, if they're paying attention or not, and how much time you have for that specific session. Choosing the next frequency to test varies according to the patient, according to the child. So it's really a case-by-case scenario. The initial intensity has to be presented at the clear suprathreshold level when you change frequency, or if necessary, it's better to recondition the child. Maybe they forget or they don't realize that if it sounds a bit different, they still have to do the same thing. Now, what if the child is not turning their head? You have a couple of things to do in this case. Either direct their attention towards the reward after presenting the stimulus. So you present the stimulus and you just move your hand in a way to tell them to look at the speaker, and then you give the reinforcement. Do that a couple of times. And if they still can't do it alone, maybe increase the intensity by 10 dB. And also vary the stimulus type or the frequency of the stimulus. And if they still can't do it alone, try increasing by another 5 dB, or try using a bone vibrator at a vibrotactile stimulus. So for example, at 250 hertz at around 40 dB. If they still can't do it, maybe the reward is not very visible. Try lowering the room lighting, uh, the room lighting, and if the child is still not responding, maybe they're not developmentally ready or not motivated enough. The last thing is the conditioned play audiometry. This test is frequency specific and ear specific if you use earphones or headphones, and same thing for VRA. And it's used for a child between 2 and 5 years old, and it's just making a game out of the test, keeping them entertained enough to do it. So you replace the feedback button with an activity to do. So for example, you tell them that every time you hear the sound, I want you to put this block above the other, so like building blocks or building Legos, or also throwing the ball inside the basket if they hear it. So first, the audiologist conditions the child around 3 to 5 times. As I was saying, you tell the child that when they hear the beep, they should, for example, place the ball in the basket, and then make sure to try to do it as quick as possible, because the child gets bored easily, and to do both ears at different frequencies before you lose the child's interest. And if they're doing it correctly, it's very good to give reinforcers such as clapping your hand or giving praise, going like, good job, you did great, and giving some claps. And if you feel like the child is starting to lose focus, there's no need to fully complete testing of one ear. It's okay if you move to the opposite ear, and because partial information from both ears is better than complete information from only one ear. Okay, these are my references, and that's it. Thank you very much.